function adequately. There are two main types of dialysis: hemodialysis and peritoneal dialysis. In hemodialysis, blood is filtered outside the body in a dialysis machine. The patient's blood is pumped to the machine, cleansed, then returned to the body. To prepare for regular hemodialysis treatments, a one-time minor surgery is performed to create a vascular access, which is essentially a large and strong vein enough to sustain the high flow rate through the machine. This can be accomplished by fusing an artery to a vein, forming a so-called fistula, or by adding a synthetic tube, a graft. For emergency treatment, a catheter can be used for temporary access. Once inside the machine, blood flows within tiny tubes surrounded by a dialysis solution, called dialysate. The walls of the tubes act as semi-permeable membranes that allow only small molecules, such as water, nitrogenous wastes, and electrolytes, to pass through. The filtration occurs by osmosis and diffusion, where water and solutes move from higher to lower concentration. The dialysis fluid contains solutes at the levels similar to those in healthy blood. Urea, potassium, and other solutes that are present at higher levels in the patient's blood move out to the dialysate, which is constantly replaced and discarded. At the same time, other substances can be added to the dialysis fluid to be administered to the patient. These may include bicarbonate to adjust the patient's blood pH, erythropoietin to compensate for its low production by the failing kidneys, and certain medications. Because of the increased risks of blood clotting associated with its contact with foreign surfaces, an anticoagulant such as heparin is usually added. The composition of dialysis fluid is typically prescribed by a nephrologist based on the patient's needs. Hemodialysis is normally performed as 4-hour treatments 3 times a week in a dialysis center. Complications include risks of blood infection, thrombosis, and internal bleeding due to the added anticoagulant. In peritoneal dialysis, the dialysis fluid is introduced into the patient's abdominal cavity via a catheter. The lining of the abdomen, the peritoneum, serves as the natural filtering membrane. The fluid remains in the body for several hours, allowing exchange and equilibrium with the blood running in the underlying vessels before being discarded. The therapy can also be done automatically at night during sleep. Peritoneal dialysis is less effective than hemodialysis, but because it can be performed for longer periods of time, the result is comparable. Peritoneal dialysis offers more flexibility, is better tolerated by patients, and less expensive, but is more often complicated with abdominal infections.
Okay, so this video is all about AV fistula creation, which we're going to talk about in a minute, but it gives a really good overview.
Introduction. An arteriovenous fistula creation is a surgical procedure performed by a vascular surgeon to create a connection between an artery and a vein. The fistula is usually placed on the forearm or upper arm. However, it may also be placed on the leg. The creation of an AV fistula increases pressure and blood flow through the vein, which makes the vein grow larger and stronger. The enlarged vein provides easy and reliable vascular access for life-saving hemodialysis treatments. Indications for arteriovenous fistula creation. An arteriovenous fistula may be indicated for treatment of end-stage renal disease. This is a common condition caused by diabetes or hypertension and is characterized by progressive loss of the kidney's ability to filter and purify the blood. Preparing for an arteriovenous fistula creation. In preparation for an AV fistula creation, a Doppler ultrasound will be performed to map the blood vessels. The ultrasound shows the speed of blood flow through the various blood vessels in the area, enabling your surgeon to choose the most appropriate blood vessel for the fistula. You will need to inform your doctor about any allergies and medications you take regularly, as certain medications such as blood thinners may have to be stopped temporarily about a week before the procedure. You may be asked to avoid eating and drinking after midnight on the day prior to surgery. Arteriovenous fistula creation procedure. An arteriovenous fistula creation involves the following steps. The skin over the AV fistula site is cleaned with an antiseptic solution, and local anesthesia will be administered to numb the area. Alternatively, general anesthesia may be administered so you are asleep during the procedure. With local anesthesia, you remain awake and may feel some pressure at the site, but no pain. A small incision will be made to gain access to the blood vessels. The selected artery and vein are incised and surgically connected with sutures. The skin incision is then closed with sutures and a bandage is placed over the incision. Recovery and post-procedure care. AV fistula creation can be performed in an outpatient setting, and most patients can expect to be discharged after a few hours in the recovery room. There may be a slight discharge for 24 hours and soreness from the incision site for a few days after surgery. You will be given medication for any post-operative pain and advised to keep the arm elevated to reduce swelling. Specific instructions will be given on how to care for the AV fistula access site. It takes about 2 to 3 months before the fistula is developed and mature enough to be used for hemodialysis. To protect the access site, you should take the following precautions. Wash the vascular access site every day and keep it clean and dry. Ensure that your doctor checks the access site before each hemodialysis treatment. Use the access site only for dialysis. Be careful not to bump or injure the access site. Check for thrill, a rhythmic vibration, over the access site, which indicates the AV fistula is healthy. Do not put a blood pressure cuff, tight clothing, or jewelry over the access site. Do not lift heavy objects with the access arm. Avoid sleeping with the access arm under your head or body. Report any signs of infection such as redness, swelling, or pus drainage to your doctor as soon as possible. Risks and complications. AV fistula creation is a safe procedure. However, as with any surgery, there are some risks and complications involved that may include excess bleeding, infection, swelling, pain, formation of clots that may slow down or block the AV fistula. Benefits of an arteriovenous fistula. Some of the benefits of an AV fistula in the treatment of end-stage renal failure include: can be used for a longer time compared to other types of vascular access. No foreign material is implanted into the body. Optimizes blood flow for effective hemodialysis while minimizing treatment time. Lowers infection risk. Can be performed in the outpatient setting. Ensures faster recovery and return to routine activities. Summary. An arteriovenous fistula creation is a surgery to connect an artery to a vein for patients with end-stage renal disease in order to receive dialysis. The result is an enlarged vein that provides easy and reliable vascular access for life-saving hemodialysis treatments.
Apparently I have to sign in because this one has age-restricted material. So.
I think I need a permission slip from my parents to watch it.
There isn't anything in graphic on this one, so I don't know.
Today I'm going to talk to you about a very special group of patients. And these are patients with end-stage renal failure and are on dialysis. Patients basically have developed renal failure due to diabetes and hypertension and some other rare causes. As a result, the kidneys are not working. They require a procedure known as dialysis, hemodialysis, in which their blood is extracted, passed through a machine to filter out all the toxins and fluids, and then replaced back into their bodies. Patients undergo hemodialysis on average 2 to 3 times per week, and they are dependent because the moment they stop going to dialysis, they will perish. Now, for dialysis to happen effectively, patients need a way to remove the blood, put back the blood into their bodies. That way of doing it is called vascular access. There are 3 kinds of general vascular access that we use. One is a line-based or catheter-based, and that's called a temporary dialysis line. That's usually inserted in the patient's neck and allows us to remove the blood and put it back in effectively. However, a temporary dialysis line through the neck is not long-lasting and is prone to infections frequently. So most patients would either have the lines removed due to infection or replaced in as early as 6 months. Instead of using these lines for long-term dialysis, we would suggest doing a procedure or surgery in which we connect the arm veins to the arm arteries. That is a process known as arteriovenous fistula creation that is usually done as a day surgery procedure under local anesthetic. It takes us for an hour. The vein will then progressively enlarge over time, sometimes about 2 to 3 months, and then it becomes visible under the skin. Dialysis nurses at the dialysis center can then utilize this fistula to perform dialysis for the patient. As a result, after dialysis, there's nothing to worry about because these structures are all under the skin and they go on and have a shower and lead their daily lives. In some patients, the veins are not that suitable for creation of a fistula. They're too small, they're too narrow, and so what we do is we insert an artificial blood vessel or graft under the skin, in which we then connect the veins to the arteries. That is a process called arteriovenous graft creation. And again, once that has matured, the patient can then use that for dialysis. So these are some of the ways in which patients with dialysis who require hemodialysis can undergo dialysis safely using these various forms of vascular access. So if you are a dialysis patient or about to start dialysis and require vascular access, please do not hesitate to reach out to us so that we can help you.
So, basically, hemodialysis access is used to prolong lives in patients with end-stage renal failure because without it, they wouldn't survive for very long. So it's used to remove waste from their blood. Typically, these patients will have to undergo many different procedures. Sorry, I have a little residue of a cold left over. Because these grafts and fistulas a lot of times do fail, and we'll talk about that more. So, the purpose of ultrasound in access grafts is to evaluate pre-op. So basically, you're assessing to see if the inflow artery that's going to provide the flow through the fistula or through the graft is adequate. It needs to have enough flow to sustain a graft. We're also going to check the outflow veins to which the graft or the fistula is connected to make sure that they are also suitable to create a fistula. We're going to perform post-op surveillance to assess the flow through the fistula and to record and monitor any complications that happen. Okay, so the first thing that we want to talk about is upper extremity venous anatomy. And so it's pretty similar to the arteries because the deep veins run with the deep arteries. So what we're gonna focus on is these veins here, the right subclavian, well, right and left subclavian, the axillary vein, which tracks with the axillary artery, and the brachial vein. And down here, we have the ulnar vein, which runs with the ulnar artery, and the radial vein. Now the two superficial veins, so those were all the deep veins because they're paired with a deep artery. These superficial veins are in the superficial part of the arm. They are not paired with any artery, so they just kind of go by themselves. So the basilic vein runs down the medial side of the arm on the ulnar side, and it joins together with the brachial veins to form the axillary vein. So here's the basilic, it's gonna join with the brachial veins up here to form the axillary vein, and then it's gonna drain into the subclavian. It's a lot shorter than the cephalic vein, which runs down the lateral side of the arm, which is the radial side of the arm. And this too also drains into the axillary vein. So the basilic and the cephalic are the two veins that are used the most for access. And this is just a closer look at how these veins interact with each other. So here's the brachial vein, that's the deep vein. The basilic vein on the medial side will join up with the brachial vein to form the axillary, and then it's going to continue on into the subclavian vein. And here on the lateral side of the arm, we see the cephalic vein all by itself, and then it's just going to drain into the axillary vein. So that is venous anatomy that we're most concerned with for this. And in the forearm, you can see the median cubital vein, that might be used sometimes. Sometimes when these grafts fail, surgeons can get kind of creative. So the median cubital vein drains into the basilic, it's also a superficial vein, and you can find this vein in the antecubital fossa. Okay, so when you're doing a vein mapping, you're going to start in transverse. And so to evaluate the superficial veins, we're going to have to know where they're located. So this is showing us a left arm. And so you see the brachial artery in the middle. It's flanked by its two paired brachial veins. And here, very superficially, you see this single vein running with the brachials. That's your basilic vein. And so on the lateral side of the arm, we're going to track the cephalic vein. And you should be able to see the cephalic vein coming off of the axillary vein. So here's the axillary artery, axillary vein, and the cephalic vein, a single vein, more superficial than the deep veins. Okay, so that's venous anatomy. So now we're going to talk about the types of vascular access that are used. So the first type is a central venous catheter. And basically they're going to place a catheter in through the internal jugular vein or the subclavian vein, and they're going to feed it through to the vena cava. This is a temporary solution for dialysis while the patient is waiting to get a more permanent hemodialysis graft or fistula. So the most common type of native access fistula is going to use the patient's own veins. That's the Breccia Semino It's surgically created fistula, arterial to venous fistula. They're going to use that for dialysis. Usually it's done from a non-dominant arm, and so the connection between the vein and the artery is usually done in the forearm. So they'll start more distally first, and then once those fistulas or grafts start failing, they'll move more proximally up the arm to the upper part of the arm. So the connection usually is between the radial artery at the wrist and the cephalic vein, which is on the radial side at the wrist. Another choice that they could go with is a brachial artery attached to the end of the cephalic vein. So the anastomosis can be end to side. So here they're showing that the radial artery is attached to the cephalic vein from the cephalic vein's end to the radial artery's side. Or it can be a side-to-side anastomosis, like here, where the radial artery and the cephalic vein are attached side by side. So the radial artery attached to the cephalic vein is the most common configuration of this fistula. The brachial artery to cephalic or brachial artery to basilic is also common. This is an autogenous fistula, so it's using the patient's own veins. Usually these fistulas have low complication rates, and they stay patent for a long time, so they're really good to use. The ulnar artery to basilic vein connection can also be used, but it's really not common at all. So once an AV fistula is created, it has to have enough time to mature before it can be cannulated. So it has to be big enough and strong enough to allow enough flow volume to flow through for the purposes of dialysis. So a mature fistula is going to look a lot like this. It's going to be very prominent under the skin. It's going to look sausage-like, very lumpy, very big. And this is going to be the efferent vein, which means the outflow vein that's used for dialysis puncture. So this is what we're looking for. So during dialysis, flow is going to go from the artery through the fistula or the graft and into the vein. And access for dialysis is obtained in the vein. The dialysis machine has an arterial needle, which is the higher pressure side, and then it draws up the blood into the dialysis machine, it cleans it up, and then it returns the cleaned blood from the venous needle to the venous side. So the arterial needle is kind of closer to where the artery is than the venous needle. So the point is that these needles need to be far enough apart so that the blood's not mixing that much, if that makes sense. Okay, so here are some basics.
Let's start this section by talking about the very basics of an arteriovenous axis, also called AV axis, used for hemodialysis. The purpose of an AV axis is to have a stable, patent, superficial venous segment where two dialysis needles can be inserted far enough apart to allow blood removal and return from it to the patient during hemodialysis. An AV axis can be either a fistula or a graft. Let's take a closer look at these. An AV fistula is where the patient's artery is connected directly with the patient's vein in an end-to-end, side-to-side, or an end-to-side anastomosis, the latter being more common and demonstrated here. What is shown is an end-to-side anastomosis between the radial artery and the cephalic vein to create a radiocephalic fistula. Following the creation of an AV fistula, the high shear stress causes both arterial and venous dilation. As the vein is exposed to the high shear stress and flow from the artery, it starts to arterialize. That is, it starts to dilate and enlarge over weeks, resulting in the formation of a mature AV fistula. So this is our newly created radiocephalic fistula. How do we know it's ready to be used? According to the KDIGO guidelines, a mature AV fistula is defined as one where the vein grows and develops at least 0.6 centimeters in width, is 0.6 centimeters from the surface, has an ultrasound flow of at least 600 mils per minute by 6 weeks post-fistula creation, and has a linear segment of at least 6 centimeters, ideally 10 centimeters, that will allow 2 needles to be placed a reasonable distance apart. This is the rule of sixes. The blood flow through the fistula of at least 600 mils per minute is important so it can sustain a standard blood pump rate of 400 mils per minute during dialysis. This radiocephalic fistula is now ready to be used for the purpose of dialysis. An arteriovenous graft, or AV graft, is a synthetic tube that is used to connect the patient's artery and vein for the purpose of cannulation during hemodialysis. This is often done in patients that don't have very healthy and well-sized vessels of their own. The synthetic tube is what acts as the vein in an AV graft and is used for cannulation. For the purpose of this module, we'll demonstrate key features around an arteriovenous fistula, but most of the discussed principles apply to an arteriovenous graft as well. Remember, a dialysis axis is not just about anastomosis between a vein and an artery. It's a closed circuit starting at the heart and ending at the heart.
Okay, so now we're going to talk about the different types of access grafts, which she kind of just touched on, and these are synthetic grafts. Usually they're made from Gore-Tex or PTFE, polytetrafluoroethylene. These grafts are placed between the artery and the vein. These are directly used for puncture. The reason why they use access grafts versus a fistula is the patient may not have suitable veins for a fistula creation. The patient may already have a fistula that has failed, so now they're using a graft instead. Access grafts are actually the preferred method in the US, although it's tending now more towards fistula creation, which actually has better patency rates than access grafts. So this is a PTFE access graft, also known as Teflon. So this is the one that's going to give you that double-walled appearance on ultrasound. So the graft can be straight, and it's going to go from the distal artery to a more proximal superficial vein. So it's going to start distally at the artery, and then it's going to go up proximally to the superficial vein. Or it can be looped. Some of them can be self-sealing, which they can be cannulated right after implantation, which means that they can be punctured and used for dialysis. They can also be tapered at the arterial end, which reduces flow volume going through that graft. So this is a reinforced PTFE graft, and you can see that it's got this double-walled appearance, and it looks pretty sturdy. So if you ever see something like this, you can bet pretty much that it's a graft. Another type of graft is polyurethane. With this graft, there's no maturation time that's needed. Once it's implanted, it can be used immediately. This one is also self-sealing. The drawback of this type of graft is that it can't be penetrated by ultrasound, so it's going to be hard to assess the flow within that graft. So So this is a forearm loop graft. So looping the graft kind of makes it longer, so it's got more length for dialysis to be able to puncture. So in this graft, the brachial artery is the proximal anastomosis, and it's looped around to the median cubital vein, and that would be the distal anastomosis. So that's the whole tract of the graft. So some other access graft locations, you can have a brachial artery to basilic vein graft, or a subclavian artery to jugular vein graft, which doesn't sound pleasant. A superficial artery to great saphenous vein loop graft. And we're not going to spend too much time on those. So this is a brachial artery to basilic vein straight graft, and it's a reverse graft. So usually grafts go from a distal artery to a proximal vein. So the proximal anastomosis would be down here, and the distal anastomosis would be up here. But this one's reversed, so it's got the proximal anastomosis way up high on the artery, and the distal anastomosis down here at the distal basilic vein. This is just another type of graft. So this is a loop graft from an artery to a vein. So during access for dialysis, both needles are punctured straight through the graft. The arterial needle usually is placed closest to the artery, the inflow artery. Access grafts tend to have a higher fail rate compared to fistulas. And grafts and fistulas are allowed to mature for up to 4 to 6 weeks before they can be used. So, this is a comparison of AV grafts versus synthetic grafts. In Europe and Asia, about 80% of patients have a native fistula access. Only 20% are synthetic, and it's pretty much reversed in the U.S. About, more than half of patients in the U.S. have a synthetic graft versus a native fistula. So this chart kind of shows patency rates at 2 years. So fistulas are about 75% patent at 2 years, versus grafts, which only 35% of grafts are patent after 2 years. So grafts tend to have a really high fail rate and a low patency rate. So really fistulas should be the preferred method, which the U.S. is slowly trending towards. So during preoperative assessment, you should be asking yourself, are these veins suitable? We're going to be doing vein mapping, where you're going to determine if the veins are big enough. Is there thrombus or obstruction in these veins? Is there enough arterial inflow to sustain a graft? We also have to rule out subclavian steel, because if there is, then it's just not going to work. And this is where palmar arch patency comes into play again. So
would subclavian steel be a contraindication for both sides?
Probably only on the side where the steel is present.
Yeah, so you could still do it on the
On the
side
other
that's
side.
receiving the flow, right? Or would velocities be too high, or?
So with steel, it's going to be taking flow away from the fingers,
Yep.
distally, which is not what you want when you're putting in a graft, because you want that flow to go all the way distally, because the graft is going to be taking some of that flow back up to the veins. So you want to make sure that the inflow to the graft is sufficient.
Okay.
So a steel would be counterproductive to that.
Either way.
So this is why vein mapping is really important. So without vein mapping, you have a very high fail rate and low patency of these AV fistulas. So that it kind of just shows you the importance of doing a good job of vein mapping for these patients. So, when you're doing an arterial assessment, we are assessing the inflow artery to that graft or fistula. So we want to rule out subclavian steel right off the bat, so we're going to do arm pressures to evaluate that. Anything above 20 millimeters of mercury is not good. We're also going to scan the brachial, the radial, and the ulnar, because those can all be used for inflow. And the things that we're looking for is just the things that we have been looking for in the past. It's stenosis, occlusion. You want to make sure to note any anomalous high bifurcation of the radial and ulnar arteries. So like instead of bifurcating below the bend of the elbow, sometimes it can bifurcate in the mid-arm. So you just want to note that for the surgeon to decide what to do. And the last thing we're going to do is measure the distal radial artery in transverse at the wrist. That's very important. So, when we're doing this measurement in transverse, you want to make sure that the vein appears rounded so that you're not kind of slicing through at not exactly perpendicular to the vein. And then you're going to measure the vein from inner edge to inner edge, as you can see here. So from inner edge to inner edge. So if that diameter is less than 2 millimeters, it can't be used. So what you're going to do is scan more proximally away from the wrist to find a segment that's at least 2 millimeters. And you're going to mark that location. Okay, so when we're evaluating the arterial inflow in the subclavian, the radial, what we're looking for is just normal flow patterns. We want to make sure the flow is adequate, normal triphasic waveforms. The distal radial artery velocity at the wrist should be greater than 50 centimeters per second.
Can you say that again?
So the distal radial artery velocity should be greater than 50 centimeters per second. Part of the inflow evaluation is to assess the palmar arch with an Allen test. And we've talked about that at least a couple times before. So we're not going to spend a whole lot of time going over that again. But if you need a refresher, chapter 12 and 13 in the book kind of outlines that. Also, the last PowerPoint that we did, I think, covers that as well. And also the upper arterial PowerPoint that we did a few weeks ago covers that as well. Okay. So, in summary, for a normal exam, the arterial requirements, you need to have the gradient between the brachials needs to be less than 20 millimeters of mercury to rule out subclavian steel. The arterial lumen needs to be greater than or equal to 2.0 millimeters. The peak systolic velocity of the distal radial artery has to be greater than 50 centimeters per second. You don't want to see any stenosis, no occlusion. The palmar arch has to be patent. That's it in a nutshell. Okay, so we've done the arterial inflow evaluation. Now we have to evaluate the outflow vein from which that graft flow is going to come through. So, there are venous requirements for AV fistula creation. So first off, the brachial veins are rarely ever used for hemodialysis access, although never say never, right? Like
Brachial?
anything can happen. The brachials, yeah. So the venous lumen diameter, measured with or without an arm tourniquet, has to be greater than or equal to 2.5 for a fistula, or greater than or equal to 4 millimeters for graft placement. The veins cannot have any stenosis or thrombosis. The deep veins have to be patent, also, no stenosis, no thrombus. The vein that you're going to use for access has to be within 1 centimeter of the skin surface, so it can't be deeper than 1 centimeter. And it has to be continuous with the proximal central veins, like the subclavian and the axillary. Okay, so for a venous pre-op exam, what we're looking for is to find the location of the basilic, the cephalic, the axillary, the subclavian, and really just any veins that might be involved in that particular surgery. And so basically we're making sure that these veins are patent. So what we're going to do as sonographers is perform a venous exam to rule out DVT in those deep veins, or deep vein thrombosis, or SVT, superficial vein thrombosis, in those superficial veins, so like the basilic and the cephalic vein. We want to make sure there's no thrombus within those veins. So we're going to do compressions for the arm veins that we can compress, and we're just going to have to rely on Doppler waveforms for the central veins that we can't compress or get to, such as the subclavian and the innominate. We're going to do vein mapping for those superficial veins, so we're going to measure the diameter of the cephalic and the basilic veins in the forearm. You can use a tourniquet. So, when we're looking for thrombus or any kind of obstruction in a vein, especially one of those central veins like the subclavian, really we're going to be looking at the waveform. So here on the left is a normal right subclavian vein waveform, and so you see that it's kind of pulsatile. It's definitely phasic because of its proximity to the heart. It's going to have respiratory variation. So this is what a normal vein would look like. Here on the right side, this is an abnormal left subclavian vein. And so you kind of have like this continuous venous flow. It kind of lost all the phasicity that it had, so it's kind of just like a rolling continuous kind of flow here. That usually means that there's some sort of obstruction, like a thrombus, in those central veins. So that's what we're looking to exclude. Okay. So post-operatively, the indications for an ultrasound duplex exam usually centers around signs of possible access failure. So like ischemia in the distal limb, like in the fingertips. If there's no palpable thrill in the fistula. Does everybody know what a thrill is?
It's a good vibration from flow.
Yeah, it's a vibration because of the high pressure flow going through the fistula. So it's kind of like a bruit that you can feel, basically. for a duplex exam is poor dialysis or increased pressures during dialysis. Access recirculation of greater than 12%. Does anyone know what that means? Yeah, I didn't either. I had to look it up. So basically, dialyzed blood comes back through the venous needle, and it re-enters the unit through the arterial needle. So it sounds like the blood is backing up through the wrong needle, instead of going back out through the systemic circulation.
Getting sent back through dialysis.
Yeah, I think that's what this means. Don't quote me on this. Is not going to be on your test.
So I have a question.
Yeah.
You're supposed to take the blood from venous to the machine and then pump it back through arterial.
No.
Okay.
So-
Opposite.
So you have your inflow artery, then you have, let's say it's a graft. Your graft is connected to your artery. The artery is going to provide that flow through the graft, and then it's connected on the other side to a vein. So it's going from artery to vein. So that vein is the access vein, right? So they're going to puncture the graft, and so the graft is connected to both the artery and the vein. So they're taking that arterial flow, cleaning it up, and then bringing it back in through the same graft. So it's going to go to the venous side, so
Okay.
from artery to venous.
But you were just saying in that instance that it was reversed.
Like, no, so some kind of way instead of the blood being, so on the venous side, the venous needle, the blood is coming out, going to the venous side. But sometimes it can back up into the needle and back up into the dialysis machine, which is not what it's supposed to do. And so it causes this recirculation, access recirculation, of greater than 12%.
So it's not like pressurized. Like it's not. It's just flowing back.
It's
to the
just
machine.
flowing backwards, I guess. I don't know. It's like it's some sort of aberration from the normal, basically. The only thing to take away from that is that it reduces the efficiency of dialysis. Okay, so the last thing that I'm going to talk about for an indication is an unexplained urea reduction ratio of less than 60%, which I also had to look up. And basically, urea reduction ratio is a parameter that assesses the effectiveness of waste removal, in this case, urea, during dialysis. So if it's, not removing efficiently, then there might be something wrong with the graft. Okay. So the post-operative scan protocol. First things first, you're going to determine the location of the access. So you're gonna find the fistula, determine what type it is and what course it's taking. Usually you can use the op notes to kind of guide you. Sometimes they're not always available, so just do your best. The next thing we're going to do is determine the indication for the exam. What are they looking for? What are the potential problems that you should be aware of? Then we're going to visually examine the patient, look for the puncture sites on the patient's arm, look for any lumps, palpate those lumps. If they're pulsatile, could be a pseudoaneurysm. These are all things that you're going to be looking for. Okay, so just like vein mapping, we're going to start in transverse with our transducer. Note the needle tracks. This will help you see where the graft is. Usually though, if it's an AV fistula, you're going to see it. If it's a graft, you probably will see it and be able to feel it under the skin. So you're going to start with a a general survey of the graft or fistula to kind of orient yourself. You're gonna scan the brachial artery down to the distal radial artery at the wrist and transverse. And you're doing that to kind of find where the graft takes off from those arteries. So what we're looking for is the origin of the graft or the anastomosis. Then you're gonna scan through the entire course of the graft. So you're gonna follow it from anastomosis to anastomosis. And then the last part of that is to scan the outflow vein. So, then you're gonna scan in longitudinal. You're doing this to assess the flow within the graft and the inflow and outflow artery and vein. And basically, we're gonna keep the orientation the same. So the distal hand and the digits are gonna be on the right side of the image, just like we've been doing it this whole time, because it can get kind of tricky to scan these grafts, especially if they're looped. Okay. So this is the scan protocol. We're going to go through each part. So we're going to start by evaluating the artery, the inflow artery that provides all the flow to the graft. This inflow artery should be low resistance because it's feeding that graft that ends up in that low pressure vein side. We're going to assess the arterial outflow beyond the arterial anastomosis. So basically, if this graft here is the proximal anastomosis, so we're going to evaluate the brachial artery proximal to that. So that's the inflow artery. But we're also going to evaluate the same brachial artery distal to this stenosis, so like right about here, to make sure that there's no steal syndrome going on there that's taking flow away from the digits. So that outflow, this inflow artery past the anastomosis should be high resistance because it's feeding those distal vascular beds in the fingers.
It's not low resistant.
Not anymore. Not once it gets past the anastomosis. It then becomes triphasic again.
After the anastomosis.
So another thing to note when you're evaluating past that proximal anastomosis in the artery, the flow should be antegrade. So if you see any kind of retrograde flow coming back up, that could indicate a steal. So you definitely want to note that. Retrograde flow, usually in the distal radial artery, like right around the wrist, can be asymptomatic if the ulnar artery is adequate enough to provide flow to perfuse the palmar arch. Although retrograde flow in the brachial artery that's distal to that proximal anastomosis usually does cause symptoms distally towards the fingers, like ischemia, things like that. So this is what arterial inflow proximal to a graft or a fistula should look like. This is normal. The waveform should be low resistance, high diastolic flow, like in this image right here. So this indicates that there's adequate inflow to that graft and that the graft is patent. As opposed to the image on the right side, which is abnormal. So that inflow artery prior to the graft should have a low resistance profile If you see a high resistance profile feeding that graft, then that means that there is a severe stenosis or occlusion somewhere downstream, typically in the graft. And so on this image on the right, the patient had an occluded graft. So that's your first sign right there, is that triphasic high resistance flow that's supposed to be providing flow to the graft. That is abnormal. Okay, so after we assess the inflow, we're gonna assess the proximal anastomosis, to where the graft is attached to the artery. We're looking for any abnormal flow, stenosis. Then we're gonna scan the entire graft, the whole length, so proximate, distal of the graft. And then the distal anastomosis to where it's connected to the vein. And throughout the assessment, we're measuring the peak systolic and the end diastolic velocities. We're looking for stenosis at the anastomotic sites. So we're going to compare the velocity at the distal end of the graft to the velocities at the efferent, or the outflow vein, anastomosis site. So once we evaluate inside the graft, then it's time to evaluate the outflow vein. So usually you want to do a Doppler just proximal or cephalad to the anastomosis site. So if this is the anastomosis site, you want to go just a little bit proximal. Usually that's the site of stenosis for an outflow vein, and usually that's caused by intimal hyperplasia. So just like the artery, since we're checking proximal to the anastomosis, we then want to check distal to the anastomosis, and we're checking flow direction. Sometimes you can have flow reverse back down into the fingertips because of the high arterial pressures. And that increased venous pressure can cause swelling in those patients. So we just want to make sure that there's no backflow going back down to the fingertips. And then if that wasn't enough, we're going to evaluate the outflow vein proximal to the proximal subclavian. So we're going to go all the way up to the subclavian vein. We're looking for any kind of stenosis, thrombus, kinking, or extrinsic compression, anything that could hinder that flow. So that sounds like a lot, right?
Mm-hmm.
Yeah. I thought so too.
How much longer do these take than a regular?
I've never done one, so I really can't say for sure, but to evaluate all the things that we just talked about probably takes some time. And also, like, you have to figure out like which way the flow's going and the anastomotic sites. So like, I feel like this takes a while, probably at least an hour or so. So anyway, so graft evaluation, I've kind of numbered the sites of evaluation in the order that they're listed in the protocol in the book and that we just went through. So if this is like confusing, feel free to like erase those numbers if it doesn't help you. But it just kind of helped me go through each step. So the first thing, which we talked about just now, is the arterial inflow, proximal to the anastomosis. So you want to start your evaluation here. Then you're going to evaluate the arterial inflow distal to that anastomosis site. Then the third step is evaluating that proximal anastomosis. Then 4, 5, and 6, you're evaluating inside the graft at mid, and distal. And then 7 is this venous side anastomosis, the outflow vein. Then 8, you're evaluating just proximal to that anastomosis, and then distal to the anastomosis, and then the last step is going up to the subclavian vein.
Yeah, isn't flow going towards the subclavian then?
No, so the arterial inflow is coming down to the digits, right? And so this flow is gonna shoot across through the graft and go back up into the venous side, which is going back up to the heart.
Yeah, so that's what I was getting at. So wouldn't, I guess, 9 be considered proximal venous flow, and then 8 be distal venous flow?
You're saying this is distal?
Isn't the blood going that way, coming out of the
The blood is
anastomosis?
going up towards the heart,
Yeah.
but to remain continuous across like proximate distal, we're doing proximate distal like towards the heart, so
Not
towards
towards
the heart.
flow, towards the
Yeah.
anatomy.
towards anatomy,
Okay.
because that gets way too confusing. So distal veins are gonna be towards the feet.
Has nothing to
proximal
do with
It's
direction of
gonna
flow.
be towards the heart.
Okay.
Not, it's not based on direction of flow. Yeah, so this is distal for a vein and for an artery, even though the flow is in opposite
I've
directions.
been thinking about it wrong the whole time. It just worked out because it was arterial.
Yeah, so. I probably should have mentioned that, but I didn't think about it.
Venus
No
is
reason
flipped.
to come up until just now.
Yeah, I mean, it makes sense to me, but, you
Yeah.
know, I don't know what you guys know about veins. So yes, the venous flow is going up towards the heart. This, number 8, that's proximal to the anastomosis. 10 is going even more proximal up towards the subclavian. So does that kind of make sense?
Now it does.
Okay. Okay, so here are some of the flow patterns that you're gonna see through a fistula. So this first one up here, labeled A, this is the inflow artery. So it's not gonna be triphasic like it would be if it was going down to the fingers without a fistula in the way, or a graft. So because it's feeding a graft, it's gonna be high velocity, low resistance. It's gonna look like a monophasic arterial flow, basically. So this one, letter B. So this is the anastomosis site for the fistula. And you can see that it's high flow, it's turbulent flow, you see all this turbulent flow pattern. Sometimes it can be bidirectional, sometimes it's just unidirectional. C here is the outflow. This is the vein that's close to the fistula anastomosis. So you'll still see like flow disturbances. This vein is arterialized, so you'll see like an arterial-like waveform. D is the outflow vein that's more proximal, so going up towards the heart. The flow is becoming more ordered the further you get away from the fistula. It's still arterialized though, so it's gonna look like a monophasic waveform. And E is the distal outflow artery. So distal to that anastomosis site should be the regular triphasic waveform because it's flowing towards the digits at that point.
Is it insinuating that where they're touching down there is the anastomosis?
Yeah,
Okay.
so that's probably a side-to-side anastomosis. Okay. So, on the outflow side of the graph, just proximal to that anastomosis is the site where, the most common site where you're gonna get this hyperplasia. So that's why it's so important to evaluate this site post-operatively, because that's gonna occlude the graft or reduce flow to the graft. So just proximal to that anastomosis site on the outflow side. And this is what intimal hyperplasia is gonna look like on ultrasound. It's kind of hypoechoic, but you can see it encroaching on the lumen.
So how do you differentiate that between atherosclerotic plaque? Like, is that more echogenic than that?
It is more echogenic, and you're not typically gonna see atherosclerotic plaque in the vein. That's usually more reserved for the arteries. But that does happen in the arteries, so it can be kind of hard to differentiate because sometimes newer, fresh plaque is more hypoechoic in the beginning stages. So, okay, so for the really fun stuff, now that you've assessed your flow through the inflow, the graft, and the outflow, it's time to calculate the graft flow volume. So, what you're gonna do is, basically you're gonna select a site that is straight, somewhere mid-graft, and you're gonna measure inner edge to inner edge, to get the diameter of the graft in transverse. So the first step is to get that graft diameter, and you want to make sure you have a clean view of it. Once you get the graft diameter, then you're going to turn long on it, and so you're going to place your sample volume right where you measured the graft diameter, the same spot. Then you're going to increase your sample volume to fit the diameter of the graft, because you want to be able to sample all of this flow in here. So make your sample volume the same width of the graft. Then you're going to get your spectral waveforms, and if the machine can do it, it's going to get a time average velocity. So not a peak systolic velocity, it's time average velocity. So basically it's an instantaneous average or the mean velocity over time. So not a peak systolic velocity. And then either the machine can calculate the flow volume for you, or you can do it by hand with a calculator with this formula. So flow volume is expressed in mils per minute, and the formula is flow is equal to the graft area times the time average velocity times 60 seconds.
You can figure out time average velocity without software though, can't you? It's just the highest, the lowest, the amount of time divided by the number of seconds.
I don't know the answer to that,
Okay.
but I guess you could. Some machines have the capability to do it, and some don't. I have never done that myself, so I really can't say for sure, one way or another.
I would just imagine it's just like average speed over a regular,
Yeah,
like if you were doing average pace of, through a marathon,
Right.
same
Right.
calculation.
So yeah. Area is equal to pi times the radius squared. Alright, so that's how you calculate graft flow volume. Okay. So graft flow volume, excuse me, is an indication of how well from 300 to 400 mils per minute, all the way up to 3,000 mils per minute, which sounds pretty high. Fistulas, however, do not tolerate high flows well like grafts do. There may be other techniques that are available to measure flow during dialysis. But basically, flow volume, you're going to calculate it with this formula here. Okay. So, what do these flow volumes mean? And what are the cutoff values for normal? So for an excess graft, less than 350 mils per minute means that there's an impending graft failure. This patient's not going to have, a good dialysis experience at all. Less than 500 mils per minute, there's an increased risk of failure. Anything greater than 800 mils per minute is considered normal. And if the flow gets too high, so anywhere from 1,500 mils per minute, that can cause possible congestive heart failure because of all that increased flow. For an AV fistula, greater than 500 mils per minute is adequate. Greater than 800 mils per minute is normal. So even though 500 isn't exactly normal, it's enough to sustain a fistula because they can survive at lower flow volumes. Okay, so some complications of grafts and fistulas include thrombus, occlusion, stenosis typically at the anastomostic sites, stenosis in the graft, stenosis at the venous outflow. Usually that one is caused by intimal hyperplasia, sometimes thrombus, arteriostele, which is going to cause ischemia in the digits, pseudoaneurysms, which are pretty common with this type of axis, increased right heart pressure because of the increased graft flow, and that can lead to heart failure. And infection is a big risk as well with these grafts, and that mostly happens in the synthetic grafts.
I had a question.
Yeah.
So, like with the thrombosis and occlusion, how often do they check the graft or fistula for a dialysis patient? Like once a year or something like that?
I think it's probably more frequent than that, but typically if during dialysis, one of those parameters, like it's not, dialysis is not optimal, they'll probably have it checked out, because there's certain parameters where, if the patient's blood is not being cleaned properly enough, that could indicate that the graft is progressing to failure. So there's probably a lot of signs during dialysis that they look out for. Okay, so let's talk about arteriostele. So sometimes flow in the artery distal to the anastomosis, proximal anastomosis at the inflow will reverse in direction because of the high flow into the graft or the fistula. So that steals perfusion from the digits. If the patient is symptomatic, you can perform an ultrasound and do indirect testing methods to kind of see what's going on. So if you perform a duplex ultrasound on this patient, you'll see reverse flow in that inflow artery distal to the anastomosis site. And so you can follow that up by doing either PVR or PPG waveforms on the digits and compare it to the asymptomatic hand. And what you want to do in that case is get digit pressures and compare it to the asymptomatic hand. Digit pressures of less than 60 millimeters of mercury usually cause ischemic symptoms in those patients. If possible, when you're doing the PVG or the PVR testing, you can try to include the fistula to see if the amplitudes increase to the digits, because that flow, if it's occluded, is not being stolen back up into the vein, and instead it's going back down to the digits to where it's supposed to go. So in the case of arterial steal, likely the patient will have to have surgery to get that graft corrected. So this is a Doppler image of the distal radial artery just past the anastomosis site, and basically what you're seeing here is retrograde flow in that artery. So that's indicating the steal. So pseudoaneurysms can happen in a graft, and usually that's a result of dialysis puncture, or just the nature of this whole situation. What you want to do though when you're evaluating for a pseudoaneurysm is to measure the size of the pseudoaneurysm. If it's big, less than 1 centimeter, it's usually not a problem, and it's likely just going to remain stable. But if it's greater than 1 centimeter, it definitely should be repaired so that it's not causing problems for the patient.
Is it caused by graft disintegration, or
No, so it's caused by puncture during dialysis.
Okay.
So all the repeated needle punctures can just cause the pseudo.
And the pseudo would cause the disintegration of the graft?
Yeah.
Okay.
It would lead to failure of that graft. You may find hematomas next to the access graft. Usually it's an old pseudoaneurysm that kind of thrombosed and resolved itself. Determine whether it's compressing the graft and occluding flow. Okay. So sometimes a lot of times these grafts can occlude. And so basically what you're looking for on ultrasound assessment is basically the same thing that we've been looking for, which is no flow throughout the graft. You might be able to see thrombus within the graft. Typically, you won't see any flow in the outflow vein distal to the graft, so that there will be no flow going through that vein. The inflow artery will be high resistance, so instead of that low resistance, high diastolic flow that should be going through the graft, you'll see a high resistance flow like we've been seeing in these native arteries. So this is an occluded access graft. It's a 2-day-old radial artery to basilic vein access graft. The signs of graft occlusion are high resistance inflow, as seen in this radial artery. So triphasic high resistance flow is a really big indicator. And then on the outflow venous side, you see really low venous outflow. So like there's barely any flow leaving that graft. So those are two big indicators. High resistance inflow and low venous outflow. were some studies done that evaluated some new fistulas and grafts, and it showed that in 72% of fistulas and 82% of grafts, that there was a greater than 50% diameter stenosis after 1 month of placement. So basically, most fistulas and grafts will develop a stenosis. So the criteria for an access stenosis is basically the same for fistulas and grafts. The peak systolic velocity should be greater than 400 centimeters per second, and the velocity ratio is either greater than 2-to-1 or greater than 3-to-1. So it can be both, because there are different studies that suggest that a velocity ratio of greater than 2-to-1 indicates a greater than 50% stenosis, and then there are other studies that claim that it's a greater than 3-to-1 ratio. So it's both for the ratio. So the velocity ratio compares the velocity at the stenosis with the velocity just proximal to the area of the stenosis. So like a normal area proximal to the stenosis.
Can you say that one more time, please?
Yeah. So the velocity ratio compares the velocity at the stenosis with the velocity just proximal to the stenosis. So like, say for example, you have a velocity just proximal to the stenosis of 100 centimeters per second. And then in the stenosis, you have 200 centimeters per second. That's a doubling of the velocity. So that's a 2-to-1. So that would indicate a stenosis. Make sense?
Mm-hmm.
So this is the criteria that we're going to use to determine whether there's a 50% stenosis for both fistulas and grafts. Okay, one last video and then we're done. Maybe not.
Winning the CrossFit Games is more mental than physical. There's a lot of incredible athletes out there.
We are looking for any areas of flow-limiting stenoses. In this case study of radiocephalic arteriovenous fistula, we are hoping the exam gives us insight into whether or not the access is working, or if there are any reasons it might not be functioning properly. We are looking for any areas of flow-limiting stenoses. Patent side branches are evidence of inflow or outflow disease. In the first couple of images, you can see the sonographer starts with the radial artery inflow. This is a perfectly normal waveform, low resistant, even monophasic. This is perfectly normal for a pre-anastomotic artery waveform. Moving through the anastomosis. And here at mid-forearm, you can see that the diameter has changed, it's increased. So we continue on. Sonographer takes measurements with corresponding waveforms. And if you notice here, there are 3 measurements. This is likely pre at the max site of diameter reduction and post diameter reduction. So in looking in these measurements, we can tell that the diameter decreases to less than half of its previous measurement. So we can expect to see some increased velocities here with disturbed flow. Let's continue on with measurements showing there's the velocity increase. And this is likely right at the area of the decrease in diameter. Now the sonographer has moved distal to that decrease in velocity increase, and we get a significant decrease in velocity. So this gives you all the information you really should need to make a proper diagnosis. Just showing how the flow continues on up the arm. And this is at the ACL. So what can we conclude from this study? Well, first, the fistula is patent. Second, 4 centimeters central to the anastomosis, a focal site is present where the diameter decreases from 1.43 centimeters to a half a centimeter. And then beyond that focal site, there is a deterioration of the waveform, suggesting that the focal stenosis is fulminating for this fistula. So that would be your final impression.
Man, if I had listened to her lecture, I
Oh,
was sleeping.
I thought she had a very soothing voice.
Yeah, soothing me right to sleep.
I was like, why is she whispering?
ASMR video.
Right.